Hi everyone, I'm really thrilled to be joining you this morning from Sydney, Australia. I wish that I could be with you, but as you all know with the COVID situation, we can't travel from Australia, so we'll have to leave that meeting till another day. I'd like to start off by thanking the organising committee for asking me to speak to you today about something that's really dear to my heart. It's the basis of my thesis, which was called Taming the Beast. And I had 8 key themes arise from that thesis, which then gave rise to lots of recommendations for MS nurses and other professionals working in MS care in order to make the journey for the patient the best it possibly could be. So I currently work for MS Australia, but I also have a research fellowship position with the University of Notre Dame in Sydney in the School of Nursing. And that's where I get to do my own research, which this project was based on. Before we get started, I'm very conscious that this is the Nikki-Ward Abel Memorial Lecture. Nikki meant an awful lot to me, so it's an absolute honour to be giving this lecture in 2021 in her honour. This is Nikki. For those of you that didn't meet her, this is a really good representation of the type of personality that Nikki was. I first met her when I was on the board of the MS Nurse Certification exam in New York. It was my very first meeting where I got to travel to the US and New York of all places. I was feeling very out of sorts after a 32-hour economy flight from Sydney, and so I rocked up to the first day of the meeting, and that's when I met Nikki for the very first time. It was about a dozen years ago now. To say I was bowled over in the first 10 minutes is an understatement. I was just a fan of Nikki's for so many years because of the incredible work that she'd done as an MS lecturer and an MS educator, and all the things that she'd done to try and make the path for people living with MS easier. But she bowled me away that day in person. I just sat back and just couldn't believe that I was meeting Nikki for the first time. And by that night we got to sit together for dinner, and I got to know Nikki out of work mode, which was heaps of fun, and she just taught me so much. So thank you, Nikki, and a lot of the things that she's taught me over the years will resonate with you as we go through the study and the recommendations. So, firstly, I'm just going to give you a quick review of the methodology that I used to do the study, just so that you can get an idea of how I did it. So I did qualitative research. I wanted to explore the lived experience of relapsing remitting MS. So working as an MS nurse, at this stage probably for about 15 years, I was really curious to do a deep dive into what the real experience was outside what we saw in the clinic, and the sorts of things that we could do to make the journey better for people living with MS. I used focused ethnography, which is a form of going into a culture to learn more about the culture. Sort of like those nurses 20 or 30 years ago that used to go into island communities to look at the maternity situation in those groups. But obviously I couldn't do that in this instance and go and live with the people with MS, so that's why it's called a focused ethnography. I used life history. I got people with MS to tell me all about their life, not just their journey with MS, but everything from the word go, so that I could get a full view of what their life was like. I used semi-structured interviews, which were all performed one-on-one, from about an hour to some of them were 3 or 4 hours in length. I then used thematic analysis to look at the results, and I used the methods of Braun and Clark, which are listed there for you for reference. I found, coming from a mainly quantitative research background, that I was really struggling with some of the aspects of qualitative analysis, and Braun and Clark just gave me all of the answers I needed, because their form of analysis is really robust and systematic, and that really suited my style of learning and thinking, and proved to be a wonderful sidekick for me for the entire study. From the data I collected, I developed codes and themes, and then these themes went on to tell a story. And that's what we're going to cover today. So who did I talk to? So there were 13 people living with MS, relapsing remitting MS, 10 females and 3 males, which just happened organically, but that, as you know, reflects the natural predisposition towards women. So that suited the study extremely well. Mean age of about 41 years. Mean duration since diagnosis was 12 years, but I had someone who was fairly recently diagnosed at about 2 years, and then I had other people that were up to 30 to 32 years, and from really diverse backgrounds, looking at their education, rural, city, working, non-working, people who were parents, people that were single. I seemed to cover the lot, and that just happened organically, but that was really great. So what I did was I developed 8 key themes that we've already talked about, but I divided them into 2 different streams. And the first one was part 1, which was walking the low road. And this really covered the first few years of being diagnosed with relapsing remitting MS, and goes through the journey pretty much in the beginning, although all of these things come back in and out of the journey with MS. And then we went on to the high road, what I called finding the high road. And this was sort of a more joyous part of learning to live with MS. And it had these 3 themes. We're going to go over them all one by one. Okay, so looking at walking the low road, and sometimes it really felt like the picture, that's me, by the way, on my bottom going down the Great Wall of China in a section that was not able to be accessed by the public. And I basically fell down to the bottom. And that's, I think, sometimes how it feels for people when they're first diagnosed with MS. So what I'm going to do is for each theme, I'm going to give you an idea about what the central concept of the theme is. And then I'm going to go through some of the sub-themes. So the sub-themes really then dig a little bit deeper into each of the themes. Then I'm going to give you an example of a quote or a situation that someone in the study told me, just to demonstrate to you some of those sub-themes. And then I'm going to tell you about the recommendations relating to that theme for your MS nursing care. So the first theme was piecing together the puzzle. Now, you will all know this story. This is the first hints, the clues, people getting help, going through all the tests and being told their diagnosis. So there were several sub-themes here that really start to tease out what's happening in that time. And that's the what's happening phase. It's when people have got vague things happening, they're starting to seek help, they may get brushed off at this point, which makes them extremely vulnerable, because if you're brushed off with the first symptoms and then you go away, you're a little bit more reluctant to come back and seek help again. The second sub-theme here was all the tests that go on as the puzzle starts to come together, and for some people that can be a really traumatic part of the journey. And then the third sub-theme is the puzzle is complete. This is the day my life changed forever. And this is when people are finally told the diagnosis after all those pieces of the puzzle come together, and they have a lot of decisions to make. Now, people told me, I had some of those people that we talked about that had been diagnosed for about 30, 32 years. When they told me about their day of diagnosis, it was like they were going right back and it was last week. It was very traumatizing for some of them. And I think it's Professor Solari from Italy has done some work on what people recall from that day, and it seems that they have really vivid recall of the day of diagnosis, and some people even report remembering what their neurologist was wearing, what colour tie they had on, and that's years later. So I think we all know that that's a really big day for people and something of great importance. Okay, so a little example of, this was Piper, who was a female in her 40s in my study, and this was an example of her being brushed off in that early phase. So she said to me, the doctor said, there's nothing wrong, you know, go away. I went to a few doctors actually during those years. I felt like a fraud because I could feel these weird things. I was really struggling. I said, I think there's something neurologically wrong with me. And the GP said, no, there's not. There's nothing wrong with you. And this happened many times. So it took Piper a process of about 10 years to be diagnosed. And then in the end, the diagnosis came quite suddenly and quickly, but she'd gone through a lot of suffering in that time. So the recommendations from piecing together the puzzle were mainly that there's all of these touch points for MS nurses to intervene to change the journey. and to put people on a different pathway. It doesn't all have to be about struggle and suffering. There are good ways that this can be done. Ask your patients about their past experiences. So if someone's new to you on their MS journey, they may have been diagnosed 10 years ago, 15 years ago, doesn't matter how long, ask them about what happened so that you've got an understanding about what's coming into the room with you and what you've got to work with. And you can do some amazing healing work, which we're going to talk about a little bit later. This also helps to build confidence and trust. If somebody knows that you're on their side and you want to know their story, that can really help give you some inroads for that long haul partnership that you're going to be building with your patient. And also just to really put at the back of your mind that the day of diagnosis is such a big day for patients, and so to plan that well. I know it's hard for us on the other side because we've got often such busy days, and you might be fitting in new diagnosis with other visits for all types of patients. And so things can get a bit out of hand, but if you just pay really good attention to people that are going to need your help on that day, tailor it to what the patient needs and set some goals for yourself, that goes a long way to creating a really good pathway to start the journey. Okay, we'll move on to the second one. So the second theme was that immediate period just after piecing together that puzzle where you've been where the patient's been diagnosed, and now they have to redefine how they're going to make sense of the world with relapsing remitting MS. Now, this had a lot of sub-themes to drill down into. The first one was getting acquainted with relapsing remitting MS, and this could take various forms. We all know that there's some people who just run away from the diagnosis and go straight into denial, and they're not sure that they want to do that. Other people want to find out everything they can about it and troll the internet and find goodness knows how many articles, and they keep deep diving down further. And there's also those people that want to go and have a look at other people with MS. And I've called these people the people who like to dare to compare. And that's when people are first diagnosed, that they have a little look around them. And it might be at the clinic, it might be going to an MS Society meeting, and they have a look at everyone around them and try and work out where they are in that sphere. Negotiating normalcy, disability and independence. A lot of that goes on in this early phase because people are trying to work out if they've had relapses, they've been disabled for a short period of time, and then they go back to baseline. Am I still disabled? Am I back to normal? Where do I fit? Working out work, next one on my list there, and that's working out all of the employment issues to do with MS, which is really important in those first few years. Parenting with relapsing remitting MS. This one came as a little bit of a surprise to me, how intensely the people in my study viewed their parenting role and the joy that parenting gave them, although there was angst with that as well, because sometimes there's a lot of angst around the choice to become parents, and sometimes when things are hard, it is hard to parent with MS. So there were lots of issues around parenting with MS. So if anybody wants to go on and do their own thesis, that's a really good place to start because there's not a lot of literature about that. And the final thing on the list there is balancing losses and gains. And this goes on in the months and years following diagnosis, where people try and make sense of the losses that they have with the diagnosis and what's gone on beforehand, but some of the gains. And some people told me about how being diagnosed forced them to rethink their whole lives and to do things much differently than what they were planning, to take risks, to go places, to do more things with the kids, and they saw that as a bonus. Now, the example that I've got for you for this theme came from Paul. He was a gentleman in his 30s that had gone through quite a difficult road to diagnosis. And when he was diagnosed, he was just trying to sort himself out with where he fit in the MS world. So he told me this story that he went to an MS meeting, and he actually chose to go to an MS meeting with more disabled people. And at this stage, he had a very low EDSS, and outwardly he looked completely normal. So he chose to go to this meeting, and he said, I don't know if this is a little bit morbid, but I wanted to see what other people with the condition were like. It was pretty depressing. I was thinking, with everything I'm reading, maybe this isn't a big deal. So I wanted to go and see progressive MS. this sounds really terrible, but it was a comfort thing. Well, I'm actually all right. So Paul had compared himself and figured that he was doing better than the other people in the room, and that gave him comfort. Okay, so some of the recommendations for redefining me now that I have MS, where nurses can play a really big role in helping people work this out, is realising that there's individual needs for education and support. So taking the time to work out where your patient is in the journey and what you can do around those themes we talked about. Early referrals. So if you can see somebody struggling, we're going to talk about this a little bit more in the next theme, get help early. It will never be the wrong thing to get help early. Teaching patients that time can sometimes take care of some of the issues in the early days of MS. Positivity, invest in skills, and in that investment in skills comes back to those referrals, getting help, getting a psychologist or a life coach, and just trying to iron out those details early. Finding out which symptoms bother people, because sometimes it's not the symptoms that are bothering us that cause them the most angst, so it's worth asking about. Talking about workplace disclosure is always an important thing. Whether to disclose a diagnosis or whether to keep it secret can often be a big cause of stress and anxiety for people in those early years. So being available to have that discussion, and support for parenting, being able to answer the questions, particularly around falling pregnant and what to expect in the time after the postpartum period, and starting medications, all those sorts of things. Okay. The next theme, this probably caused me the most deal of stress, and also putting me into a bad place while I was doing the study. I really struggled when I got to this section because of some of the stories that I heard from the people that I interviewed. And I called it Battling the Demons. And it's all about confronting and living with these negative emotions, the things that steal joy away from life. And certainly for about 4 to 6 months, I needed to get some help for myself while I battled all of these codes and themes and thoughts, and reliving these experiences that people had told me about that had really caused them a lot of stress in their lives and really stole away some of the joy. And they're things that we've all seen before. I'm just putting names on things that you're regularly seeing in clinic all the time. And the biggest one here was facing fears. There was so much fear expressed to me by people, and sometimes some of this fear went back 20 years, 30 years, and it was fear of lots of different things. It was fear of the symptoms or relapses. It was fear of DMT side effects. It was fear of progression or disability. Or one I actually gave it came up so much and it was so profound that I actually gave it its own little category, which was fear of the wheelchair. And we've all seen that in clinic, where people are just so fearful of what lay ahead that it can really detract from them gaining any positivity and getting some positive outcomes for themselves. The second one was weary from worry. Sometimes all the worry just causes so much anxiety. And often this was centered around being a burden to family. And this sort of had two sections. So it was being worried about immediate family and children and being a burden there, but also being a burden to their parents. And a lot of people struggled with telling their parents that they had MS as well, and that caused a lot of worry. Some people I spoke to really got into the depths of despair and depression, and had big issues then that cropped up over time. Other people had short periods of what they referred to as depression, and they've found ways around that, which we'll talk about in Taming the Beast a bit further on. And then we had this group of people, and I called it struggling with the saboteurs. These were the things that would get in way of life and come up and rear their ugly heads sometimes at the most inopportune moments. And it was sometimes coping around the uncertainty of MS and not getting any certainty around what's going to happen next, or how it's going to happen, or where it's going to happen. That felt like people had something on their shoulders all the time. The concept of never being free, and also the concept of being socially isolated because they were too scared to go out. So this was a pretty dark chapter, as you can see. It does give rise to some more wonderful things later on, but it's just good to be aware of what's going on. Now, this was an example of the fear of the wheelchair I spoke about. So Susan was actually a registered nurse in her 30s. She was diagnosed quite young. She was about 18 or 19, and had a great deal of trouble with relationships and forming relationships all through her 20s. I think she was about 35 when I first met her. And it was all centred around this: I'm very, very scared. Well, if it's MS, am I going to be in a wheelchair? Or what's going to happen? Will I meet someone? Who's going to look after me? You know, will I be a burden? Thinking, I don't want to end up with her because she might end up in a wheelchair. I might have to look after her. And she freely admitted to me that she'd lost probably one of the best decades of her life just from this fear. I'm happy to report that she did find somebody after probably about 4 years ago. She would be close to 40, and she's just recently had a baby. So she's now living her best life. So these are my recommendations for battling the demons. Look for prior resilience clues in your patients. So when you're meeting somebody for the first time, and particularly if it's close to diagnosis, although the timeline doesn't matter, ask about what's happened in their life that's caused them a battle in the past and what they did to get through it, because that might give you some clues about what might help them this time. And that could be confiding in friends, it could be seeing a psychologist, it could be walking in nature and looking after mental health. But find out what's worked for them before, and that also gives you a good starting point to dig a bit deeper into their life to find out what's going to work. Address depression and anxiety as early as possible. And just the realisation that uncertainty is a battle. Just the uncertainty of MS can cause so much angst for people over and above the disease itself. Assess the emotional well-being every time you see them. Sometimes people who are quiet, they may not talk to you about the issues, but quietness can be fatal. So every opportunity you have, assess the emotional well-being of your patients. And look for and address those fear points. So have open and frank discussions about the fears and what might be bothering them. And finally on that list, and it's very important, but looking for signs of post-traumatic stress disorder. Always be alert for those signs, which includes things like flashbacks, nightmares, social isolation, and be ready to pounce on that immediately for some help. Okay, the next theme. Surplus suffering. The central concept of surplus suffering is suffering inflicted by others onto the person with MS over and above that MS would cause itself. I was really excited when I went to a qualitative analysis workshop in the US. It was actually a week before a major MS meeting, and I was lucky enough to go. And it was around the time I was really struggling with this concept because I was seeing it repeatedly. I was seeing that people were telling me that they'd had really compromised care, which was a real bother to me, that this had been caused by some of my colleagues. And people really suffered from it. And this was on top of their MS and all the things that they had to deal with there. And it really caused me a lot of angst trying to work it out. And I went to this qualitative conference, and I was a bit sceptical about going, but it ended up being the best thing because there was somebody there presenting work on fibromyalgia, and they spoke about this concept of surplus suffering. And as soon as I heard it, I knew that that was describing exactly what I was seeing in the cohort of people that I'd spoken to. And so Joanne Clark, she's an American sociologist, and she has done a lot of work here. And so she's done work with surplus suffering for parents looking after children with cancer and parents with mental health, parents of children with mental health disorders. And so I read her work and it just resonated really well with me. So I brought it back to our MS world, and since I've done that, I've had a lot of feedback that this sort of helps answer some of the things that you see in practice that you can't quite put a handle on. So I drilled down a little bit more into this and found that there were different types of surplus suffering. A big one was one inflicted by brush off, like we talked about with Piper before. Then there was surplus suffering inflicted by healthcare professionals in clinical care. So just in the normal course of clinical care, things that were done and said which greatly affected the people living with MS in a negative way. Then there was some specific to research. And then there was surplus suffering also inflicted by their friends and family in the community, which I also found incredible to hear those stories. I hadn't heard that in my normal practice before, but it came up quite often. So I've got two examples here. I've got one of surplus suffering inflicted in clinical care, and I have one inflicted by family. So the first one is the story of Joy, who'd had probably about 12 years of symptoms before she was finally diagnosed. And she said, and they were quite profound symptoms. She lived in a rural area where there wasn't a lot of medical care, but she said to me that I went deaf and my right leg and arm were weak. But once again, he, being the doctor, wouldn't send me for tests to see if I'd had a stroke. And I thought, you've got to be joking. He refused to do any tests on me. I just felt despair. It nearly broke me. And in fact, as we went on to talk, it did break her for a number of years, until another dozen years later, and she just happened to meet the right neurologist at the right time who did the right tests, and she was finally diagnosed. An example of surplus suffering inflicted by family was the story of Davina, who was also a registered nurse. And she had 4 children and a husband, and she told me that her husband was extremely unsupported. He didn't want to know about her MS, and he shared that attitude with the 4 children. He never supported me. So then it became them against me. If I was having a really bad day with awful fatigue, they'd turn around and say, "Don't pull that MS card again." He would never defend me, and it was devastating. It was a really hard story to hear. That story actually very sadly went on for quite a while with lots of other different concepts that she brought into it. But I'd never quite heard stories like that before taking part in this study and having the time to really sit down and talk to people about what was going on at home. I also will say up front too that I had known this person for a long time, and I never had any indication in any of the clinical care that we'd done together that there were any issues at home. So it was a big revelation. So always worth asking how things are going at home. And that brings me to the recommendations to tackle surplus suffering in practice. Now, the first one is probably my biggie for the day, and we'll talk about it more in the end, but the MS nurse leads by example. So we practice holistic and empathic care. People look to us for clues of how to handle things when they're not easy, because none of these things we've talked about so far are easy. And although we don't always realise it, people are looking to see how we handle the situation and what we're doing to make it better. So just taking that extra minute, just to give someone dignity and respect, particularly at the challenging times that they're going through, makes a huge difference on their end. So always try and do that if you can. And any stage that you get a new patient, it doesn't matter where they are at the journey, ask what has gone before, what their journey's been like till they got to see you. Because there may be a lot of healing that you can do with investing that time and getting to know them and working out how you can make new goals together to make things better in the future. And acknowledge their knowledge. Acknowledge what they've learnt about themselves, what they've learned about their families, and what they've learned about the disease along the way. We're not the experts by any stretch of the imagination. We do that in partnership with the patient. So the final theme in this first little bit of walking the low road is high invisibility. And this is the presence of invisible symptoms and their impact upon life with relapsing remitting MS. Now, as you all know, the invisible symptoms make up such a big part of the symptom challenge with MS and can cause a lot of discomfort for people, not just the physical symptoms, but coping with their emotional needs around handling them. And so then I dug a little bit deeper to sort of find out what that was all about. But there were some good things as well as things that weren't so good with this sub-theme. So it's about striving to make the invisible visible. So please see me. And the secret one, which is sexuality. Now, the men in the study brought this to my attention, that that's something that rarely gets talked about. And even if they did bring it up with their neurologist, which one of them did, it was quickly dismissed because they didn't think there was anything that could be done about it, or there wasn't much to do about it. And Nikki would be proud of that one, because sexuality was something that she was really big on, and before it became fashionable. Nikki had been talking about this for, oh gosh, now it would be 15, 16 years ago. She first wrote a paper on sexuality on MS. So it's that striving to make what's important to me that you can't see be seen. Then the second one there is reverse stigma. Now, I gave it this name because this is what happens when MS wasn't enough for people that were around the person living with MS. And that could be family, friends, or complete strangers. And that's that concept of that you can't see my symptoms, you're not sure that anything's wrong, or I don't look disabled enough for you that I have MS. And that could be really challenging and a really difficult thing to work through. So just to be aware of that. Then there was actually a good aspect, and that was invisibility as a welcome cloak, I called it. Or the downside has an upside. And that was the people that sort of welcomed that invisibility, that people didn't automatically know that they had a chronic condition, or that they were on medication, or that they had any sort of disease. And for some people that was a really important part, and a good part about MS. Now, just to give you an example of reverse stigma, and this was the first person that I interviewed that brought this to light for me, and I was just astonished. So Griff by this stage would have been a man in his 50s. He was diagnosed quite late. He'd probably been living with MS for about 30 years at this time. And he was at an MS meeting when he was newly diagnosed. So he said to me, there was a young girl in one of those wheelchairs that you never really get out of. Her mum's absolutely distraught. She saw me chatting with some of the other blokes, and she came over and attacked us. What are you? What are you doing here? You haven't got MS. That's always been at the back of my mind, that I'm a bit of a pretender to the throne. And that had caused him an immense amount of grief over the years following his diagnosis after this incident happened, because he'd never sort of seen himself that way. And this concept of being a pretender to the throne has followed him and caused him a lot of grief, as I said. So just summing up the recommendations to try and make the journey a lot better for people living with invisible symptoms. So often open and frank discussions at from a very early stage. You set the groundwork for that these things are okay to talk about, that they're not taboo, no matter how sensitive. And that could be for the issues with sexuality. It could be something even as simple as if someone's having bowel or bladder problems, that you might even say, look, you know, we're working together to try and fix your bladder problem. If there's a bladder issue, there may be problems with sexuality. Do you have any concerns on that front? And just give people a little bit of a gentle edge to sort of get in and just normalise that this is okay and this is something that you're going to talk about at every visit. Getting help early for invisible symptoms is also really important so that you can prevent things building up. Helping patients rehearse, and this is a bit of a strange concept, but I found it really useful, helping patients rehearse how to present their invisible symptoms to others. So you might just run through some narrative with them about how they might present that to their family or to their workplace, and get them to understand that although they look okay, there might be things going underneath the surface that are affecting them that day. And they can find that really helpful to find the right words and give them some confidence. And also teaching them how to ask for support, how to ask for help when they need it, especially with invisible symptoms where sometimes people tend not to want to if they're living happily with that welcome cloak that protects them. They may not want to ask for help. So you can give them some ways to find things that are going to work for them and ways that are going to work. All right. Now we get to the better stuff. So now we're going to talk about finding that high road. So the next three themes start to build on the things that we've already talked about, but finding those good places where people with MS can learn to live with MS and MS learns to live with them. Okay, so we'll go on to the sub-themes of Taming the Beast. So the first one is finding my North Star, and this is all about finding what's important to you and things that you can reach for that bring you joy. And I'm going to give you an example of that in a second. The second one is getting a handle on relapsing remitting MS and the symptoms and relapses. And we've all probably seen that point where we know that somebody gets it when they're going through that mental checklist of, could this be a relapse? Do I have a temperature? Could something else be causing this? Is it from exercise? Where they really start to get comfortable with making those assessments themselves. And this is usually from the skills that you've given them, that you've trained them in, and working out where they are with that. The third thing is really what we do with brain health these days, isn't it? Which is maintaining physical and mental health and wellness and looking at all aspects. And you've all seen it where somebody after they're diagnosed will go on a bit of a health kick and try and get more fit or try and look at their diet. And that can be an important way of regaining control. The next one is one of my favourites, and this is choosing the medical A team. And that is making sure that people feel comfortable in knowing that they have every right to have a neurologist that they feel comfortable with, that they can be honest with and open with, as well as an MS nurse that they can relate to, because it's such a long haul partnership that's such an important part of that concept. And then they may look outside of that to, do I need to see a psychologist or a physiotherapist or an exercise physiologist? So building their A team. And I actually recommend extending that beyond the medical part too, into family and friends. So those people that make you feel good, that make you feel confident, that you can be honest with. Important to get lots of those people on your team as well, and teach people how to do that. The next one is harnessing support from family, friends, organisations and workplaces. That's teaching people not to be scared to ask for help when they need it. And I think we're really good at showing them the way there, particularly with things like postpartum care or after relapse care, just to not be frightened to ask. And then the last one there is riding high on resilience. And those are the people that, when they have a bit of resilience, they really start to shine. They're starting to think that they've got this and that they can move forward and there can be a life outside of MS for them. So an example of finding my North Star was Will, who was a guy in his 30s. He was diagnosed when he was only 18, and he had been on and off therapy for a long time. And he was in a really dark spot just before I met him. And then he said to me that after staying at home for 6 months and not participating in life, I'm sick of being that guy that never used to go out, go home from work and go to sleep. I just said to myself, I'm not going to go home and sulk on my own and live in circles anymore. So I joined a sporting team. I'd go and play with my friends, and I just decided to live an active life. And as it turns out for him, once he started doing that, he met lots of new people, lots of new activities, and that's just continued to this day, about 6 years on from that time, and just leads an incredibly active life. But for him, it was that sport and being with the people he met through that gave him his North Star. So my recommendations for Taming the Beast. Encourage a supportive and individual team with recommendations. So don't be scared to tell people things that they could think of to make their A team better. Who do you want there? And also look at wellness and brain health in that as well as a really important component going together. Giving people guidance on how to ask for help and groups that might potentially suit them. So some people are really well suited to a support group and other people just aren't. They would rather not go there, and you can give some guidance on what might work best for them or things that they could try and at least give a go. Reflections and narratives from other patients. Now this is a really powerful one, and I'm not sure that MS nurses realise how powerful this can be. So these are the narratives that you can give to people to help them reflect on situations. So if things aren't going very well for them, or it might be a certain type of relapse, it might be a problem with one of the DMTs, could be anything. For the nurse just to relate back that they have seen this before and how that story went for other people. And that can be really powerful for people living with MS to hear, because then they know that people have been down this road before and they've survived it. And sometimes that can be a bit of a mushing together of several stories. It doesn't have to be a completely true story. It can bring different concepts that are going to suit the person that's in front of you. And it just helps them know that other people have borne this before and survived, and that can be something that they hold really close. And helping families and others understand how they can help. So that can be as simple as having other people in on the consult and giving them some advice, particularly around those invisible symptoms that we talked about, and what they mean and what they can do to help. And that's also good for the significant others or the family, because they feel like that they really can get some control back to the situation as well. Okay, the next theme is the DMT dance, and I like the way that this played out because it does feel like a dance some of the time, doesn't it? And this is about negotiating coping with the medication therapies to treat relapsing remitting MS. And so the sub-themes here, there were two big ones. And the first one was I called the hard yards. So that was making decisions about the DMTs and whether to adhere. And then that came down to two sub-themes. One was decisions driven by fear, and the other one was decisions driven by hope. And I found this really interesting because I found that this described to me something that I'd seen in clinical practice almost daily for years and never really understood. And these are the people that make decisions and you sort of scratch your head a little bit and think, gee, I wouldn't have chosen that. I wonder how you got there. And so when I really boiled it down, there were these people that made their decisions about their therapy based on fear, and there were people who made those decisions based on hope of something better. And I'll give you two examples of that in a second. The second sub-theme was switching to a better life, and these were the people that it was primarily people who were on injectables for a number of years and then switched over to oral or IV therapies once they either became available or they were able to access them, and just how much better their life became when they didn't have to do the self-injections and have those side effects. And that was a really heavy theme for a lot of people that took part in my study. So this is an example of the fear versus hope concept with DMTs. So the first one was Joy, and her decisions were definitely made by fear. She actually decided not to go onto a DMT at all, even though there were many that were available to her. And she said to me, I don't see any point on going on a drug that could potentially kill me. A drug that's not going to cure me and doesn't really alleviate the symptoms. I would rather be in a wheelchair than dead. Well, it doesn't get any more frank than that, does it? And then the second one was a different approach, and this was from Paul, who said to me, he worked in construction, by the way, and he introduced me to this concept of front load risk. So he said, I've developed a new MS brain lesion. This was a single brain lesion that wasn't causing him any problems, but my thoughts on this is how I want to proceed with a front load risk. I want the new drug. And the drug he was talking about was alemtuzumab. So he was quite well controlled. He'd had one new brain lesion in a number of years, but he wanted to go straight on to alemtuzumab because of that front load risk. I didn't know what that meant, so I had to do some research on it. And that means in construction, putting everything into it at the beginning to get a better outcome. And that was the way he saw it with MS. So he was basing his DMT decision on hope. So recommendations from the DMT dance. So active participation with DMT decisions. Invest the time in patients so that they have a really engaged and active discussion with you about options and how to start and how to adhere and how to move on and how to manage side effects, because that time invested can absolutely change the journey. Ensure that their perception is realistic. Ensure that what they think is going to happen with this drug is really what's going to happen, in the limits with which we can do that, of course. Touch on adherence at every point. Don't assume that everybody's taking their drugs at the right time, in the right doses, repeatedly. So always check that. Every time you have a chance to touch on that point, whether it be a phone call or a clinic consult or an infusion date, just check on the adherence, and not just to the medication but to the safety monitoring program as well. Consider health literacy with all of the DMTs. Of course, it's really important to run through and understand what people understand. Do they really have a good understanding of what those side effects are or what's involved in a safety management program, so that they're going to adhere to it? Because you really want them to set them up for success in the future. You don't want them to fail their first medication therapy simply because they didn't understand some of the aspects. And also get them to build their own support network for adherence. So if that means having someone else in the family help them remember to take a medication, or ways to help them find that easier, get in as many family and friends as they can, and teach them to build up their own support network that's going to meet their needs and work for them. Okay, now this is the final theme, and this was a biggie. And I called this one Holding Hands with Hope. And this was all about hope and positivity. So it's about reaching the happier times. So this is when people really start to accept their diagnosis and how it fits into their life, looking to the future with hope, bringing its own peace. And this was a real, actually I love that word because it really described it. It was a real feeling of peace and settling into it, and sort of really finding their mojo. So there were two big sub-themes, and the first one was hope in its many forms. And you might think that hope's just hope, but as these people told me, no, there's all different types of hope. So there's functional hope, which is hope to go back to the function that they were before they were diagnosed or before they had their first symptoms. Restorative hope, which is the hope to be restored to the person that they were before MS happened. Curative hope, obviously hope for a cure in the future. And defiant hope, which is that real kicking hope where they just want to kick MS out of the park and get on with life, and that in itself, by taking that action, gives them hope that the future's going to be better. And the second one was purposeful positivity, and I really like that concept too. That's the concept of waking up in the morning and choosing to be positive, of choosing to take control and thinking, right, I'm going to make this day the best day I can. And some of the ways that people did this were with optimism and just having a positive outlook. And I've thought about this a lot, and I think it is something that we can teach. I think it's something that we can educate on, and it's something that we can give clues to people about how to do that, because for some people that is such an alien concept to them that they just don't know where to start. And obviously some good psychology or life coaching can help with that, but there are also some simple things that MS nurses can do to help with that as well. Searching for meaning. A lot of these people I spoke to really tried to find the meaning of why this had happened to them, and once they started to form that really helped them move on. Harnessing a sense of humour. Also can't rely on this enough. I'm not sure this is something you can teach, but you can certainly teach people to look at the funnier side of things. And I had a great example of someone showing me or telling me about that they were so frightened of going in the wheelchair that became a real sticking point for them for a number of years. And in fact, they refused and had a number of falls in the meantime. And then finally had the courage to get a wheelchair for a trip to Europe, and were going over cobblestones in France and being pushed around and shoved around, and just how much fun that was for them. And that was that finding just that sense of humour in the ridiculous of the situation they were in. And that can be a really rewarding thing. Looking at faith and religion and spirituality can also be important for some people. So having an awareness that might be their way, that might be their pathway to hope. And the last one, also really important, and that's giving back and being involved. And sometimes they might need a push from us or from other MS healthcare professionals on ways that they can do that. And these are the people that like to take part in the MS readathons and the bike rides and raising money for MS research. And that can be a really important starter to getting on with positivity, and then that giving hope for the future. So this was an example of defiant hope, because this was sort of difficult one to get words around. And this was Evie, and she said, I did go bungee jumping straight after my MS diagnosis, mind you, just because I could, trying to prove a point. And now I'm almost 40 and I still do those things. I went indoor rock climbing a few weeks ago. You're not going to get me. It's not going to happen. And she's obviously talking about MS. You're not going to get me. And that's the way that she portrayed this form of defiant hope. So the recommendations for holding hands with hope. Remember that hope's never static. It's always changing. So find out where that currently is with the person in front of you in the clinic or in the hospital room or wherever you are. Find out where they are with hope and how they're feeling about that at the moment. Inspire, demonstrate, nurture, coach, lead by example, because if you're a hopeful MS nurse and you've got value, you place value in the DMTs, or you place value in a referral or a new treatment, that inspires and it coaches people to look to that. And not just patients, that can involve families as well as other healthcare professionals. Remember that one of your best tools in all of this is storytelling, to tell stories of people that have gone before and where they started and where they ended up and some of the things that they used to give them positivity and hope. That can be a really important starting point, as well as, of course, providing advocacy, counselling, referrals, just even making a simple referral. If you made a referral to a physiotherapist or a psychologist, that inspires hope, because then that teaches that there are things that can be done to help and that you believe that they might be successful, which can sometimes be a really welcome thing. So educate about positivity, how to give back, the things we talked about, how to be purposeful. So to give back, to participate in community events, and to get garner a sense of humour. And this needs self-awareness and care by the MS nurse. And I've put this in here with Nikki's name as well, because Nikki was one of the best people that I ever saw do this really well. She knew how to have a good time and look after herself, and she also knew when to be very serious and where work was at its most important. And it was that self-awareness and that self-care. That was something that Nikki taught me, and I probably didn't see the value of it as much in the beginning, but certainly over the years I definitely did. And that's something that I think if you're practicing that yourself, that gives patients hope as well. Okay, so they're the 8 themes and a very long list of recommendations. You can read about them a little bit more if you want in the full thesis. Obviously there's a huge volume that goes with that to describe it. But I think it's really important to know that the themes all flow into the ebbs and flows of life. They're presented logically in this presentation, but that's not how it always happens, and you don't go logically from one theme to another. That would just be a fairy story, wouldn't it, for everybody? It just doesn't happen like that. And at any stage of the journey, you can go forwards and back many and multiple times. For example, if you had a surprise pregnancy on one of the drugs that was likely to cause fetal abnormalities, and that might be due to a failure of birth control, for example, that can cause someone who's in a really good place and purposely positive and holding hands with hope to bounce right back to piecing together the puzzle, redefining me, battling all those demons about what we're going to do about it, and perhaps even surplus suffering. I hope not, but perhaps. And then back onto the DMT dance. As well. So you can see they all intermingle with each other to tell the story, and it really never ends with MS, because it's, as we all know, it's a lifelong chronic condition. So I just want to finish with something that I hope gives us hope and positivity as MS nurses. We lend strength so very well. We lead with kindness and hope, and I think that that's apparent in most of the connections that we have with our patients. We lead with compassion. Our example heals how we handle things, and how we handle surplus suffering, and how we handle the vulnerable, and how we handle people that have been through really tough situations. Our example can help heal them, but people notice. The other healthcare professionals around us notice what we're doing and how we're managing those situations, and I think that they learn from us as well. And that's why I mean be like Nikki. Nikki had such a great love for her patients, and it was because she believed in all of these concepts. Now, on the far left here, this is one of my favourite quotes. So Eric Hassel is a physician who did a lot of work on suffering and suffering that patients go through. And this really resonated with me as something that MS nurses do, and do incredibly well. And that is, recovery from suffering often involves borrowing the strength of others, as though persons who have lost parts of themselves can be sustained by others until their own recovers. And I think that's what we do as MS nurses. We lend strength. We don't take away, we don't lead the way. We empower, we lend that strength, until people can regain their own. And hopefully by following some of those recommendations that we've talked about, we can make the journey with MS much better, and we can get people onto pathways where they're empowered and they're confident and they're living their best life. So, thank you.